Thank you everyone for joining today's afternoon report. For those who don't know me, my name is Taoran Lee. I'm one of the third-year residents. So today I'm going to present a case of a patient with altered mental status and fatigue. So let's start our case. So here we have 86-year-old African-American female presented to the emergency room with a progressive generalized weakness and fatigue in the past 3 days. She was brought in by her son, who has found her confused and was looking for glasses that she does not wear. And past medical history-wise, she has atrial fibrillation, she has hypothyroidism. She was recently admitted to an outside facility 5 months ago with a recovered HFrEF. Initially, the ejection fraction is 16%, and upon admission, it improved to 58%. And the course was also complicated by Streptococcus galactiae bacteremia, where they did a TTE, show no vegetation, and the patient refused further TEE. And also, the course was complicated by a cardioembolic stroke without residual weakness. Patient doesn't have any contributory past surgery history, no contributory family history. And at baseline, she's a very highly functional attorney who is still working, and she works with the worker. So I'm going to make a pause here. Does anyone have any questions? Can bring up. I can unmute and bring up.
Feel free also to use the chat. Sorry.
Is her HFrEF ischemic, like her cardiomyopathy, or it was a stress-induced cardiomyopathy?
In the other hospital, according to the discharge summary, they didn't do any further tests because patients refused any invasive tests, including the TTE and also the cardiac cath.
And Taoran, Matthew asked if you can go back to the first slide, the prior one.
Oh yeah, of course. As Frida is answering, so no, she is not taking any thyroid medications. And according to the SAM, the hypothyroidism has been going on for a while. And the patient refused to take medications because she's worried about the side effects.
Like any symptoms like fever, chills, things like that, like.
Well, the son didn't measure the temperature, but according to the EMS, when she brought her here, she doesn't have any fever.
Or dysuria or urinary symptoms.
She does not complain of that. She didn't because her mental status is like a little bit altered, cannot engage a very good conversation. So we don't know yet. At the point that she arrived to the emergency room, we don't know.
Neri is asking any over-the-counter medications.
No, she does not take any coagulation either for AFib. So she was giving anticoagulation while she was in the outside facility 5 months ago, but the patient stopped taking anything upon discharge. And a little bit more detail for that admission. So she was suggested to, she got IV antibiotics while she was admitted, but the patient doesn't want to stay longer to receive the IV antibiotics. So they came up agreement that to discharge the patient with a PO antibiotics. And the son was unclear if she continued to take that or not.
Any dementia in recent past?
No signs of no dementia. Patient at baseline was a highly functional attorney, and according to the son, she still works sometimes.
Any focal weakness?
No.
No facial droop, no.
So we can go to, we can go further question. I mean, we can go to further details about the case. So medication-wise, at the time of her presentation to the hospital, she's not on any medication, and there's any drug allergies. So, and on the review of system, she has a decreased oral intake and per appetite in the past 3 weeks, associated with fatigue. It's negative for fever, and it's negative for nasal congestion, doesn't have cough or shortness of breath according to the sun, doesn't complain of chest pain, abdominal pain, nausea, vomiting. Well, the son didn't report any dysuria frequency upon admission. Negative for neck stiffness. She does have a chronic ulcers of her bilateral lower extremities, basically at the anterior shin area. And neurological wise, the son mentioned the generalized weakness and there's altered mental status. Otherwise, the review system is negative.
I think we can move forward unless you guys have any questions.
Okay. So upon the arrival to the emergency room, we have a blood pressure of 89/62 with a MAP of 71. She has a pulse of 68. Her temperature is 90 degree Fahrenheit. Respiratory rate is 19. And on the scene, according to the ESS, she desat to 80 to 70% on room air. So she was placed on non-regulator. And when she got here, the SpO2 is 100%. And on the physical exam, it's an elderly female, lethargic, and the positive physical exam findings including a dry mucous membrane. There's also positive microglossia, a positive of JVD. Cardiac auscultation showed irregular heart sound with a normal S1 and S2. Clear breathe sound bilaterally, no wheezing or crackles. Her abdomen is soft, non-tender, non-distended. And on her extremity, it was cool. And there are 3+ mixed feeding and non-feeding edema up to the thighs, with again the chronic ulcers that I mentioned at the bilateral ankles. It's clean without any discharge. And neurological exam, she is ill ×2, but she's very lethargic and sleepy. Although she was able to slowly arousable to the voice and able to follow some simple command like open her mouth, stick out her tongue, and squeeze, move the toes. And her facial appearance is symmetrical, and there's no phase of the nasal labial folds, no tongue deviation. She is able to wiggle toes and the fingers pretty much, a little bit movement of extremities. Otherwise, because of her mental status, unable to perform a full neurological exam. And her skin is dry and cool to touch. Very dry, I would stress that.
Any question, guys, at this point? I do have a question. I want to know about this edema. Is it something new, and when did it develop?
The edema, I'm not sure. Let me recall this. If we talk with the son, didn't mention specifically like swelling of her legs. I would say it's a new presentation for this time.
Were there lower extremity pulses, like the dorsalis pedis pulses on both feet?
Pulses are good. The pulses are good. It's palpable.
Okay, so does anyone want to kind of put together the case and tell us their problem representation before you show yours? Maybe you can go back actually so that people can see and remember some of the information. Otherwise,
go.
okay, thank you.
So we have an 86-year-old female with a past medical history of AFib, hypothyroidism, presented with altered acute or altered mental status and fatigue for the last 3 days in the setting of getting any of her medications. Found to be hypotensive, hypoxic, with bilateral lower extremity swelling. With recent hospitalization for bacteremia, not clear if she finished her antibiotic course.
Yeah, so basically we have an elderly female, and now we see that she's hypotensive, hypoxic, and hypothermic. I don't know if you want to show your summary statement, Taoran.
Yeah. Okay. Sorry, let me close this so it doesn't block anyone. Yeah, kind of similar. The statement is elderly female with a history of AFib, hypothyroidism, recovered HFrEF who is not compliant to medication, presenting with acute onset, generalized weakness, and altered mental status. Found to have lethargy, hypotension, hypothermia, microglossia, JVD, and bilateral lower extremity edema.
I would probably add to that summary that she was also hypoxemic and that the edema was non-pitting, because the fact that it's non-pitting is a clue to the diagnosis, right?
Right, exactly. Yeah, that's one.
Okay, so then like now, what I wanted to discuss a little bit about before we have more information about the case is basically if we have a patient that's so hypotensive, right? So the blood pressure of this person is 80/60. So how do you define this, and how would you approach something like this? Okay, so we have severe hypotension, right? In someone that is so why does she meet SIRS criteria though, Frida? Does she actually meet SIRS criteria?
She has hypothermia, so I think she does.
So she is hypothermic, that's true, but the blood pressure is not one of the SIRS criteria. And she's not tachycardic, and we actually don't know her white cell count. So I think right now we can have a suspicion. We need a CBC before we can say that she meets the SIRS criteria. So I think when we find a patient like this in the ED, what is the most important thing that we need to kind of address? Is her vitals, right? So we need to stabilize the patient. And I think most of the time, someone that is, hypoxic and not alert and hypotensive can be in a status of shock, even though hypotension can sometimes not be in patients with shock, but most of the times we will have someone that has a state of hypoxia of the tissues because the body is not delivering oxygen, or there is a very quick consumption of oxygen, and most of the times we're going to have hypotension. So how do we break our shock usually? How do you guys kind of picture shock in your mind? Anyone? So like when you're thinking about shock, how do you guys usually kind of divide it in your mind?
Yeah, so usually I think the way we think about it is we try to divide it between, is it hypovolemic or cardiogenic or anaphylactic or septic?
Right. So we have cardiogenic, hypovolemic, then we have distributive shock and obstructive shock. And I think a quick way to think about shock is basically thinking about our blood pressure, which basically depends on our cardiac output and on our venous resistance, so systemic venous resistance, vascular resistance. And the cardiac output depends on what? Okay, I'll say it.
Stroke volume and heart rate.
Perfect. And our stroke volume depends on what? So on the ejection fraction, so the contraction on the heart, and then the preload, which is basically kind of correspondent to the central venous pressure. So if we have this in mind, it's very easy to differentiate different types of shock. So starting with cardiogenic shock. So what's the first hit that the body has if we have cardiogenic shock? So what is not working of all these variables? The cardiac output, right? So the heart is not working. So we have a decrease of the cardiac output. And what's going to happen? We're going to have some kind of mechanism to try to compensate for that. So the venous resistance is going to increase. So we're going to vasoconstrict peripherally, but our preload is also going to increase because the heart is not pumping the blood. And what are causes of cardiogenic shocks? The most frequent cause of cardiogenic shock? Yeah, so definitely ADHF, MI, so any type of cardiac injury. So valvulopathy also, any type of arrhythmia can also cause cardiogenic shock. Exactly. So usually for valvulopathy, like Frida said, some valve rupture, so something that it happens very acutely will cause. So cardiac tamponade, it causes shock, absolutely, but most of the times we're going to see that. So what's the difference between a cardiogenic shock and an obstructive shock? So if you look at the hemodynamics, they're actually basically the same. So for an obstructive shock, you also have a decrease of the cardiac output. You have an increase of the systemic vascular resistance. And then you have an increase of the central venous pressure because the heart is not pumping. But the big difference is that in a cardiogenic shock, the problem is in the heart. So the heart is not pumping because maybe there's an MI. In an obstructive shock, the heart technically can pump, but there's something that's not allowing it to pump. So for example, obstructive shock can be a PE or even a tamponade. And the mechanism of these two are actually different because in a PE, there's something obstructing the right ventricle, exactly for the tension pneumothorax. In a tamponade, what happens is that basically the heart cannot dilate. So the preload decreases because there's no blood that can go to the heart. So the mechanism is a little different, but then the hemodynamics are very similar. Now going to the hypovolemic. What's the first problem in a hypovolemic shock? So it's the cardiac,
resuscitation.
Hmm?
Resuscitation and control the bleeding if there's any bleed.
Absolutely. So that's your treatment. But as Christina is saying, so the decrease SVR. So the first problem is that you have a decrease of the blood or the fluids of the body. So the first set is actually not this SVR, sorry. I meant to say there's a decrease of the preload, so the amount of fluid that we have in the body. So what happens? That the SVR also increases, so you kind of vasoconstrict peripherally to try to pump the blood pressure up. What happens to the cardiac output in hypovolemic shock? Does it increase or does it decrease? Increase. So I'm there with you. So we're saying that cardiac output is heart rate and stroke volume. So the heart rate will usually increase. Most of the times, if you have a hypovolemic shock, that means that you're losing so much fluid or blood that you're going to have not enough stroke volume. So most of the time, the cardiac output will decrease, but of course, the heart rate will try to increase. And of course, hypovolemic shock, as Fatma was saying, any type of hemorrhagic shock, but also think about very severe GI losses, severe skin burn, or also, for example, heat stroke, they can all cause a hypovolemic shock. Going to the last one, so distributive shock. What is distributive shock? What happens here? What's the first hit? The heart, the blood pressure, like the vasoconstriction, or the preload? So exactly, so there's going to be vasodilation. So that's the first hit in distributive shock, that we have massive vasodilation, which will bring to us, so the cardiac output tends to increase because even if we have a vasodilation and some fluid will be lost because of the inflammation and the increased permeability of the endothelium, you tend to have an increase of the heart rate and not such a big decrease of the stroke volume like in a hypovolemic shock. So most of the times, initially, you have an increase of the cardiac output. Sometimes it can decrease at one point. And then what happens to the CVP? So most likely it's either normal or it will be low. So there's not actually an increase of the preload. So we have exactly, Francis, low filling pressures, perfect. What is the most frequent cause of distributive shock? You guys all know and treat it every day.
Sepsis.
And sepsis is actually the most frequent cause of shock in general. And sometimes we use this value to kind of differentiate septic shock from cardiogenic shock. So this is basically the measured O2 that we can find if we have a central line and an IJ. and you measure the O2 saturation in the blood, that kind of tells you the amount of oxygen that's going back to the heart after it basically went throughout your body. Do you guys know what's the usual normal value for SpO2? We check it a lot in the ICU.
60 to 80.
Sorry, Noor, what'd you say?
60 to 80, but I guess it would
Yeah.
be the most
More or-
accurate.
Yeah, more or less, yeah, 65 to 75, around 70%. This is the normal amount. And what happens in cardiogenic shock is that this decreases because basically the heart is not pumping, so the blood is kind of staying there. So you're not bringing new oxygen to the tissue. The tissue is extracting more oxygen than normal, so that will go lower than 65. While in sepsis, it tends to remain normal because you have a high output and a high contractility of the heart. So sometimes we use, especially if we have a mixed shock, because that happens pretty frequently. And septic shock actually can cause cardiogenic shock. So it's not uncommon to have both. What other causes of distributive shocks we can have besides sepsis?
Neurogenic.
Okay, perfect. Anaphylaxis, big one. Anything else? More, I'd say definitely more rare. Yeah, neurogenic, and also some of the metabolic causes like adrenal insufficiency, because you lose the tone because there's no minor, exactly, insufficient. Perfect. So now that we have an idea of how kind of shocks work, once you have a patient that we're saying that it's in shock, what do you have to do? Like first steps in the ED or in the ICU, wherever you are. Fluids. So you have to kind of stabilize the patient. And usually we kind of go, it's like ABCD, right? So we, first of all, we actually have to make sure that the airway are fine and that the patient is breathing. Cultures, yes. So let's go step by step. So the airway are the first thing, because as we said, this patient, for example, she's hypoxic. She's coming with a 60% oxygen. And we are seeing from the case that Taoran brought that actually with the non-rebreather, she's fine. But I want to just bring up one point that the patient might be hypoxic because maybe she has cardiogenic, I don't know, shock and she has fluid in the lungs, but she might be hypoxic because she's altered because of the shock that's causing neurogenic, issues. So sometimes the problem is that the patient is not going to be able to maintain the airway. So we always have to make sure that we don't just shove a BiPAP and leave the patient, but we make sure that she or he does not need to be intubated. So then, as Carlos said, second thing, hemodynamics, so fluids. So we always give IV fluids to these patients. What type of IV fluids do we give? D5, NS, LR, what do you guys prefer?
Crystalloid, isotonic crystalloid.
Perfect. So we don't want anything that's going to go outside of the vessels. And then the amount of fluids, I think it's really tricky because if it's sepsis, we already know it. We do the 1 liter, then we do the 30 cc per kg. But if it's cardiogenic shock and the patient has pulmonary edema, I don't know how much fluids you can actually give to the patient. And then most of the times, per definition, if the patient is in shock, they're not going to respond enough to the fluid resuscitation. So what's your next step? The patient is hypotensive. You gave them 4 liters of fluids. Okay, vasopressors, great. Go to care, okay, Patrick. If you want to do quick care, that's not the route for you then. But perfect, pressors. So what's our go-to for pressors? And if you want to tell me why. So MAPS more than 65, that's our goal. Sometimes if the patient's chronic hypertension, but what's our goal? Like what's our go-to? What's the first one that we always use everywhere? Levofed. Okay, so Levofed is norepi. And the action is a pure catecholamine, right? So we're gonna have beta 2 first, then higher doses, we go to beta 1, and then higher doses, we have to go to the alpha 1, which is the actual vasoconstriction. Beta 1 is more or less 3+ in terms of intensity of the beta 1 agonism. And I think it's probably one of the go-tos because it has a good vasoconstriction, doesn't cause too much tachyarrhythmias. But as any type of catecholamine, it will be very sensitive to hypovolemia, hypoxemia, and also acidosis. Usually, if the levofed doesn't work or it's not enough, what's our go-to as a second line that we usually add on to the norepinephrine? Vasopressin. Frida, do you know why? Different receptor, absolutely. So this is going to increase the cardiac output and the SVR. So different receptors, so V1, V2, so totally different, not catecholamine. pH independent, exactly. So when we're using this norepinephrine and we saw that the patient, I don't know, we're increasing the doses, not working, the blood pressure is not going up, always let's think about these three possibilities. Of course, let's treat them, but then we can use vasopressin because it's not as sensitive to the acidosis, to the hypoxemia, so we can kind of avoid levofed to go to very, very high doses, which will at one point cause tachyarrhythmias because it has a beta 1 activity. So vasopressin will only increase our SPR, but also sometimes our preload because of the vasoconstriction. And usually it's also used as a second line with norepinephrine instead of epinephrine because it cannot show the mortality benefit. So that's why we go to the vasopressin. It's a vasoconstrictor, so can trigger ischemia sometimes in patients that have CAD because of the vasoconstriction. So now let's say that we are using these two, but they're not working. What do we add? Okay, epi or phenylephrine. I think they're both fair options. So epinephrine, again, same story. It's a catecholamine. So lower doses beta 2, then beta 1, then alpha 1. But beta 1 is actually stronger than norepi. So the risk with epinephrine, exactly, but it depends on the heart rate because epinephrine will increase the heart rate, will cause tachyarrhythmia. And that's why it's usually less preferred over, for example, vasopressin as a second agent. The other thing, what is the only indication for a first line epinephrine drip or any way to use it as a first line medication? Bradycardia, I don't know if that's our first line, but there's a specific indication where you don't use anything else. Okay, okay, where's my cardio? Anaphylaxis, perfect. Do we know why? What do you mean VC, Padma? Vasoconstriction. Yeah, so the vasoconstriction action is actually very similar, but if you think about the physiology and how these two norepi and epi are made, they're actually different because norepinephrine is a neurotransmitter. So it's actually produced usually and mostly in the neurons. So it will go from the neurons to the vessels or to the heart because they are, innervated. But epinephrine actually mostly is produced in the adrenal glands. So it's actually a hormone and it goes in the blood. So going into the blood, it actually has a more effect, for example, on the bronchi. So it will have more bronchoconstriction I meant bronchodilation, than norepinephrine. So when you have anaphylaxis, you prefer epinephrine. All the other time, you actually don't go with epinephrine as a first line, besides when we are running a code. So that's that. Now, another thing that epinephrine causes is lactic acidosis. So if you're trying to clear your lactate from a patient that has shock, a reason why it's not, clearing it might be because of the epinephrine itself. Okay, so now, what other options we have? I think Frida had said phenylephrine. Do we know how phenylephrine works? Alpha 1. And Fatma, yes, even the glutamine and dopamine, even though they're a little bit different. Yes, so it's a pure alpha. So it's only vasoconstrictor. So it's going to just give us this. It's not going to affect the heart. So basically, we're going to use it as a first line only in situations where we already have a severe tachyarrhythmia. So patients with AFib with RVR and hypotension, we usually go with phenylephrine. But any other situations, we will use phenylephrine as an add-on, for example, in patients that are already on norepinephrine on a higher dose, and we cannot increase the dose of the cardiac output medication, so of the inotrope, basically. And another good thing of phenylephrine is that the half-life is very, very short. So if you give it IV, within 20 minutes, it is gone. So actually you can use it as a bolus most of the times. For example, in the OR, they use it as a bolus because it will sustain the blood pressure. For example, if you have to do any type of procedure, and then quickly the medication will go away. Okay, so now someone said dopamine. Do you guys know what's the mechanism of dopamine? I mean, I'm sure you guys know, but do you want to tell me? You don't want to tell me? I'll tell you guys then. Okay, so lower doses, exactly, Carl. So it depends on the dose, because lower doses will go to the dopamine receptors, then it will go to beta 2, then it will go to beta 1, and then finally it will go to alpha 1. So the lower doses actually will cause a decrease of the systemic vascular resistance. So we need to go to the higher doses to have this effect, and they will also cause increase of the cardiac output. So actually dopamine initially was one of the medications that was most used. We have it in our crash carts, for example, but then it was seen in some of the trials that when you compare it to Levophed, when you use dopamine, actually you have an increased mortality in patients with cardiogenic shocks, probably because it increases the heart rate more than norepi, because the beta 1 effect of dopamine is similar to epinephrine, so it's 4+, while norepinephrine is only 3+. So that's why it's not really used as a first line. But we do have it in the crash cart. I don't know if it's only because of the fact that they can use it at room temperature longer times than norepi. But basically, if you're on a code or if you're on a rapid response on the floor and you need to start like a drip, you will start dopamine initially, and then usually you will change to something else when you're in the unit. And then Fatma also said the butamine. So I think the butamine is a little bit different because it is a catecholamine, but it mostly acts on beta 2, beta 1, again, depending on the doses. The alpha 1 effect is very, very small. So it's basically a medication that you use to help the heart, but you don't help the blood pressure. So the only real first line indications is when you have acute decompensated heart failure and you really want to kick the cardiac output and increase the cardiac output. But if the patient is hypotensive at the same time, you really need a second agent to sustain the blood pressure. And then good thing about the butamine, like phenylephrine, has a very short half-life, so it kind of will act pretty quickly if you need, to sustain the heart more quickly than other medications. What's the last one that we are missing here? Very similar action to the glutamine. Ketamine, you don't really, exactly, milrinone. Yeah, so milrinone is also indicated for cardiogenic shock if you need to sustain the heart. So for example, when you have acute decompensated heart failure, but again, it will not really increase the blood pressure. It does not act on the catecholamine system, but it's a PD3, so a phosphodiesterase inhibitor. So actually, it will increase the cardiac output, but actually works as a vasodilator, especially in the pulmonary vessels. Exactly, it's a pulmonary vasodilator as well. So you have a little bit of difference in these medications. And the milrinone also has longer half-life, so it will take more time to get into action, but also more time for the body to eliminate as well. Okay, so now that we have an idea of how we can approach the patient, of course, the treatments for the different types of shock will depend on the type of shock. So this is more what we do initially. And then, of course, cardiogenic shock, we will have to find out why the patient has cardiogenic shock. Hypovolemic shock is probably the only type of shock where you can give more fluids before you start using your pressors. But most of the times you will need both. And of course, let's always remember, if the patient is bleeding, you do not give only fluids and you do not give only blood. You need an MTP, so massive transfusion protocol, to avoid hemodilution of platelets of the coagulation system, because that will cause actually worsening of the bleeding. Okay, so now I think, Taoran, you can start your screen out again and we can continue to go over the case.
Okay, sounds good.
don't see it yet. Anyway, in the meantime, let's say that we have this patient. What do you guys want to do in the ED? What are we doing besides? We already talked about the fluids, the oxygen, and the blood pressure. What are we doing next?
All right. Yeah. All right. Thank you, Julia, for the detailed introduction about shock and the management. So I think now we know that the patient's in shock, although we are not clear what category it is. So I just want to take a moment to ask anyone if, what our differentials are, what workup we wanna order at this moment. CT had
CT had
TSH,
TSH, lactate, okay.
lactate.
And lactate, I mean, we all know that it can help you define shock if we are thinking that the patient has sepsis and we do not know yet. If a lactate is more than 4, you already know that their patient is in septic shock despite the blood pressure. So that's also helpful to kind of diagnose the patient. What else are we guys getting? Besides, of course, CBC, BMP, which we will, of course, get, lady, absolutely. Cortisol level. Why do you want a cortisol level, Frida?
I mean, it could be adrenal insufficiency. She's, I mean, especially if she's hypoglycemic on the labs and she's hypothermic and with hypotension, I would think about that.
Yeah, and also I think Noor initially said she has hypothyroidism. She's not treating her hypothyroidism, and we know that hypothyroidism can go along with adrenal insufficiency. So definitely we have to check for that as well. And then focus, of course. Yeah, we want to see what's happening in her lungs. We want to see what's happening in the heart. She's also a history of FREF. And we know also that she was bacteremic. And I remember Matthew saying, do we know if she cleared her bacteremia? We don't know. So I do think we don't know why she's in shock right now. She might have any of the things that we just said, most likely. Okay. So Taran, do you want to start and telling us what happened?
Yeah. So here's the lab workup. I'll just point out all the positives. So her hemoglobin is 10.8, and 5 months ago it was 8.3. And her MCV is 88, and her platelets also decreased 60s. And on the CMP, she has a creatinine 2.7. 5 months ago is 1.8. Her sodium is 146. Chloride is 112. Glucose is 104. It's actually not low. Albumin is 2.5, and she has a mildly elevated total bilirubin 1.7 with the alk phos 151. And ESR is very low because of the.
And Frida is asking, what was the baseline of the platelets before?
Yeah, actually, I need to take a look at that. Well, my understanding is that is not a new thing. Yeah, I should include that. Let me take a look at the patient chart, but let me go further away. So here we have a UA. It shows large leukocyte esterase and a lot of white blood cell, red blood cells, also many bacteria here. And on the VVG, she's acidotic at 7.19 with a CO2 of 58, and her lactate is 1.5. We also did a BNP, it's around 584. We had serial troponins initially is elevated and then it's downtrended. The UTOX is negative, and we did a quick respiratory biovirus negative during culture blood cultures collected. Just logging in to see that if we have a baseline. To my understanding is that there is not acute decrease of the platelets. So platelets it's been low. And this is her EKG.
Anyone want to attempt to read it? Can I call out Francisco?
Sure. I don't see P wave and it seems irregular and she has a history of AFib, so I would say it's AFib with moderate ventricular response. I don't see any conduction abnormalities, and the voltage seems to be preserved in both extremity and precordial leads. And what is also remarkable is I don't see a good R wave progression in precordial leads. This could be significant maybe for a past history of MI, especially from B1 to B4.
Great.
Yeah, basically that. Yeah.
I think we all agree.
Good. So there's no acute concerns for MI at this point. And this is a chest X-ray.
Anyone that volunteers?
There seems to be significant cardiomegaly. The cardiothoracic index seems to be significantly increased. Also, there seems to be like bilateral pleural effusion, and also like apical cephalization compatible with severe congestive pulmonary edema as well. And also we cannot rule out, especially on the left lower base, opacities concerning for infiltration for pneumonia or infection as well.
Yeah, I think from all the data we have, we might have a picture even like of mixed shock, because we don't know yet if her heart failure is getting worse, but it does look like, as Francisco said, congestive here in the chest X-ray. But we also have a UTI from the urine, even though the patient is not symptomatic, but she's altered. So we don't know the culture if they're going to grow anything. So I don't know if that might be septic, that might be cardiogenic shock. And also, I want to say the lactate is normal. And we also had the physical exam with the mixed, with the impeding and non-impeding edema and also the macroglossia. So I think there's many things going on. And Taoran, I don't know what happened to the patient after this.
So I heard someone mention POCUS, and this is a POCUS that the cardiology did in the ED. I'm sorry. One more time. I think for people who has done any ultrasound POCUS elective, put any comments on that?
I mean, I
How
think
do you evaluate this ejection fraction?
I think it's okay if you just tell us,
Okay.
unless anyone wants.
So yeah, here is the parasternal short axis at the papillary muscle level, and for normal, like a normal cardiac function ejection fraction, we should able to see that those like the distance between these two papillary muscles should be less than 50% contraction at the time when they're contracting. Definitely in her case, it's not function very well. It's like I would say in a severely reduced, roughly is 10% to 20% ejection fraction. Okay. And this is the thyroid function that we did. She has a TSH of 122 with nearly undetectable free T4 and free T3. We did a random cortisol level. It's within normal limits. So for the sake of time, I'm just gonna jump to, can we discuss a little bit in the shock? And in this case, is there anyone want to put any comments? What should we do at this moment? Rita, for answer your question, we don't have, oh yeah, you asked before, sorry.
So what we have here is like clinically and based on your exam and based on the lab finding that the patient having like a mixed edema coma, maybe in the setting of her UTI or recent urinary infection.
So we're putting everything together. First of all, it's a shock, and we have a POCUS showing there's a reduced ejection fraction. So it's cardiogenic shock. Also, there's a signs of possible UTI. So I would also put septic as a part of the component. So I would say this is a mixed septic and cardiogenic shock in the setting of myxedema coma.
I would be cautious with, how we interpret that urinalysis, because, that urine sample actually had squamous cells, right?
It's a possible for contamination.
To me, it looks like, vaginal fluid mixed with urine. So I'd be cautious with saying that she has a urinary infection. We based on this UA, we really don't know. And if she wasn't having the symptoms, then it's less likely, I would say. She's gonna get antibiotic coverage anyway, I'm pretty sure. But there's very little to hang on to a urinary infection.
I think like the biggest challenge in this patient will be how to manage the fluid, because it's a component of septic and cardiogenic shock. So how to manage the fluid will be very, very critical in this patient.
In her case, we didn't give we didn't give any fluids because basically because of her severe reduced EF, and also there is a possible signs of a volume overload with lower extremity edema, and also there is some trace pleural infusion on like congestive picture on chest X-ray. So what we did is, so because she's in shock, so she was admitted to ICU, and we started levofit directly to maintain a good hemodynamic. So I think I can go further back there. So that's what we did for day one. We admitted the patient to the MICU. We started levo drip for persistent hypotension and severe reduced ejection fraction. We consult cardiology, and also because patient has oliguria at the same time, so we started marinal assistant diuresis to ensure a good urinary output. We also started heparin drip for AFib. We started broad spectrum antibiotics with cefepime and vancomycin, and also we started the hormone replacement therapy with hydrocortisone and levothyroxine. So I just want to go back a little bit, talking about the myxedema coma. So myxedema coma is defined as severe hypothyroidism secondary to the decreased, secondary to like a low thyroid function, and it's normally leading to a decreased mental status and hypothermia, which are the two hallmark clinical presentation of this condition. It is a medical emergency with a high mortality. So a part of the two hallmark presentation, decreased mental status and hypothermia, the patient may also present with hypoglycemia, hyponatremia, signs of hypoventilation, including hypoxemia and hypercapnia, and also EKG changes, including a prolonged QT, low voltage, pericardial infusion, and pleural infusion. And this condition normally happens in the patients with a prolonged hypothyroidism, normally untreated, which is in our case. And it's normally precipitated by infection, cold exposure, stroke, and some medications such as like amiodarone, lithium, or also most importantly, sedative medications, especially opiates. And apart from the hemodynamic and abnormal labs, some patients may also present with myxedema phase, which is shown here in figure 1. We have our old lady with, on the day of admission, demonstrates periorbital edema, sparse hair, loss of the lateral third of the eyebrows, and microglossia. And this is her 3 weeks after IV levothyroxine replacement. So for the diagnosis, once there is a clinical presentation present with altered mental state and hypothermia, we should always consider severe hypothyroidism or myxedema coma. So the confirmative diagnosis is a full thyroid function test with TSH, free T4, and T3, as long as cortisol. And as we mentioned before, the reason we want measure cortisol is because we want to rule out adrenal insufficiency before replacing thyroid hormone. Here is an article about the diagnostic scoring system for myxedema coma. So this study has been proposed based on 21 patients diagnosed in myxedema coma. It's an article about it's 20 years ago from Penn State University. And the scoring system gives points to the degree of different systems, including temperature, neurological function, GI functions, precipitating events with or without cardiogenic dysfunction, and metabolic disturbance. So I would say this is a very helpful tool for us to kind of give us a hint and some supportive evidence of if we suspect myxedema coma. But because the participants is kind of, the number of participants is kind of small, there are only 21 patients. So the usefulness is still limited. It's not part of the diagnostic criteria, but it's a good hint for us to use. So as far as the management, there are two parts for the myxedema coma. The first thing is the supportive management. As we mentioned before, for a shock, which is commonly seen in myxedema coma patients, vasopressor or inotropes. And we normally start empiric broad spectrum antibiotics, even in the absence of fever and leukocytosis. The reason is that in a picture of a shock, if there is a concern for septic, whether it's fever or hypothermia, we don't want to miss the components of sepsis. And also, myxedema coma is commonly precipitated by infection events. And for hypothermia, we use warming blanket. Hyponatremia, we use normal saline or hypertonic saline based on severity of hyponatremia. And also ensure adequate ventilation. And we want to start a stress dose of hydrocortisone. Normally, it's a 50 to 100 milligram IV for the first dose. And as far as the thyroid replacement, the recommended initial dose is 300 to 600 microgram IV with a maintenance dose of 50 to 100 microgram. But according to the guideline, this is not like a mandatory dose. What we need to do is to like individualize the dosage based on the patient age, weight, cardiac status, because we don't want to over replace, because like over replace will put more harm to the patient. And we will see later that in this patient, we actually didn't give the standard dose of 300. Instead, we give like rather lower dose. And also there's a controversy of giving T3 administration instead of T4. And the people who advocate giving T3 are based on the fact that T4 is more like a poor hormone, and the T3 is like 10 or 15 times more active. So it takes like shorter time of onset and will give a better recovery of for patient who has like severe profound hypothyroidism. But again, for people who hesitant giving that, is the worry that this will cause some adverse, especially cardiac events such as like AFib, cardioembolic events. So here I just want to go back to the case. We mentioned earlier about the day one, what we did. So I will jump to the dose that we give. Here is the standard stress dose of hydrocortisone. And in this patient, according to the endocrinology recommendation, we only give 75 microgram. And the patient doesn't require higher level of levofat, so we continue the dose on the second day. And on the second day, the blood culture is positive for Pseudomonas aeruginosa, so we continue cefepime and stop vancomycin. The repeat T4 is slightly elevated. And on the day 3, the urine culture for Klebsiella. So we continue cefepime, and also we are able to stop marinol infusion given improved urinary output. And on a day 4, we're able to wane off norepinephrine infusion. The patient is more awake and interactive. And I've spoke with the endocrinology fellow about the case, because the patient doesn't have like a profound decreased mental status, like total coma, doesn't protect the airway, so they recommend continue the dose of 75 micrograms daily. Right now, the patient has recovered while she's still in the hospital, waiting for cell placement. Okay, it's a little bit over time.
Thank you, Taoran.
Was there an understanding where the Pseudomonas came from?
Well, the Pseudomonas, well, we think it's maybe it's a little bit longer. It's like about 5 months ago. So we think it might be some components of hospital acquired, but it's not really exactly sure where that come from.
No, Frida is asking, how quickly did the mental status improve?
She has improved. So she's progressively improving. On the first day, she like minimal words, and on the second day, she's able to like wake up, have some interaction, like say yes or no, like give some answer about how does she feel. And finally on the fourth day, she's more awake and pull out her IV, and she said she wants to go home.
Thank you. No one has any other comments. I think we can call the day. Thank you so much for joining us. Oh, is asking, how long did you continue IV levofed or levothyroxine? Sorry, no.
Oh, so for the IV levofed, actually, it is the time that when the patient's able to tolerate the mental status good enough, tolerate PO, and she passed SLP, they switched her to PO levofed. A PO levothyroxine. Not recall the exact day, but I think it's around maybe day 5 or day 7.
Thank you. Thank you, Taoran. Thank you, Dr. Pigolini. Thank you, everyone.
Sorry about a little bit over time.
No, it's fine. Bye, guys. Have a nice afternoon.